Welcome back, students. In this movie, we're going to learn about communication disorders. As was mentioned in the introduction, my name is Dina Bonneke, and I'm a licensed and certified speech-language pathologist. You may have heard speech-language pathologists being referred to as a speech pathologist, SLP, speech teacher, etc. It's all the same. Some of us have preferences on what we like to be called, and some do not. But just so you are aware that in general, all of these terms mean the same person. I will be narrating Module 12 for you. Just so you know a little about me, I'm currently working on my doctoral degree in special education at Illinois State and have been working in a school for 8 years. I created these updated modules based on Dr. Thompson's original modules. I hope you beginning educators find them useful and enjoy. First, let's talk about the difference between speech, language, and communication. As you may have read in Chapter 10, speech is how we express language with sound. If a child has a speech disorder, it means that they are not making the sounds correctly. Speech is the most difficult and amazing way we express ourselves. This is because it involves the use of many muscles and body parts required for breathing and forming sounds. In addition to all of these, it requires the brain to make the right decisions on how to move these body parts and what to say. Different from speech, language is the rule-based system we use, which includes the understanding and expression used for communication. Components of language include the sounds of our language, the rules of how we form words, how we string words together, the overall meaning of the messages we use, and how we effectively communicate language in social situations. So it is possible to make all of the speech sounds correctly, but not understand how to combine the words, the sounds, correctly express ideas and information, or not understand the information that someone else is speaking. There are two types of language. They are called receptive and expressive language. Receptive language refers to what one understands when others are communicating. With expressive language, speech and understanding can be normal, but the way you express language can be impaired. We will talk more about language in the next video. In this movie, I'm going to talk to you about speech problems. Probably the thing about speech problems that is the most unfair is that people make judgments about others' overall intelligence based on the ability to speak clearly. This is unfair because someone can have a speech disorder and be very intelligent. But unfortunately, speech is akin to personal appearance in that it is hard to make a good first impression if one doesn't speak clearly. Give some thought to that during this module. The bad news is that speech disorders are very common among younger elementary age students. But the good news is that speech disorders among young elementary age students are the most remediable, or the most fixable, disability that we have in special education. Most times, when a child is diagnosed with a speech disorder, they are in their early elementary grades, and they have an articulation impairment. And that leads us to the concept of communication. Communication is the use of verbal and nonverbal behaviors to impart or exchange thoughts, opinions, and information. So communication involves at least two people interacting with one another and is the entire reason why speech and language are important. One can have perfect speech, master the rules of language, but actually be a very poor communicator because communication is more encompassing than just speech and language. However, it is very hard to be a proficient communicator if one has not mastered the basic speech and language skills. Therefore, speech and language skills are necessary but are not the only things you need to communicate effectively. Because speech and language are the foundation of communication, we want to try and correct problems in speech and language as soon as possible. The correction of these problems can begin at any age, but the earlier the better. As you can see in the slide, there's a lot more to communication than just speaking and understanding. Speech and language disorders are among the most prevalent disabilities in our schools. Overall, about 2% of the school-age population is currently classified as having a speech or language impairment, and therefore these children have IEPs to address these problems. Although about 2% of the school population is classified as having speech or language impairments, a full 5% of the school-age population, or 1 out of every 20 students, at one point in time, does get identified. Boys are more likely to have speech and language problems than girls. Most of the children that do get identified are identified between the ages of 6 and 12, and most have problems in the form of articulation problems. But the articulation problems are usually corrected after only a couple of years of therapy, so be aware that speech and language impairment prevalence figures are highly skewed towards the elementary school years and towards articulation disorders. Again, the bad news is that speech disorders are very common among younger elementary age students, but are the most easily fixed. You can see on the slide that we will be discussing several speech disorders. We'll discuss voice disorders, which are problems with pitch, loudness, or quality of the voice, and fluency disorders, which are problems with the flow of speech on the coming slides. But for now, let's talk about articulation disorders. An articulation disorder is basically a motor problem in which a child would have trouble coordinating their oral structures, their airflow, or both, and this causes the incorrect speech sounds to be produced. When you think about it, speech is a very complex motor act. If we ask ourselves what is physically involved in making speech, we would have to consider coordinating the tongue, the jaws, the teeth, the cheeks, the lips, the flow of air, etc. So articulation disorders may result from difficulties in any of these physiological aspects. There also may be abnormal structures in the mouth that cause articulation problems, or faulty hearing, in that the child is not actually hearing the sounds correctly. If difficulty hearing were the case, an audiologist, which is a hearing specialist, would become involved. When a speech pathologist is working on articulation, they usually go through the following evaluation steps. First, the therapist would want to know if the child can hear their own mistakes. For example, if they can correct the child who says whiff instead of with just by bringing it to their attention. Once the child knows it's a different sound, and if they can't make the correct sound, then the child can work on producing the correct sound. When working with the child on producing a new sound, a speech therapist is going to cue them. The therapist is going to help them produce the new sound. For example, help them make the TH sound by showing the child where to place their tongue in their mouth and when to blow air. The speech therapist will work on those skills with the child, first in isolation, meaning the sound by itself, then they're going to practice F and TH, then the therapist is going to work with the child on using that sound in syllables, words, at the phrase level, the sentence level, and finally in structured conversation. When the child is at a point where they're consistently producing the TH sound, when they're reading sentences from a book, conversing, etc., then it's a good sign that they have become automatic and the articulation problem is corrected. As I mentioned, articulation problems are probably the most successfully corrected problems of all problems in special ed. The final word on speech disorders is the importance of paying attention to the age of the child. All children make articulation errors when very young. By 18 months, a child's speech is usually 25% intelligible. By 24 months, most children have 50 to 75% intelligible speech. And by the time the child is 3 years old, it is usually anywhere between 75 and 100% intelligible. By kindergarten, they should absolutely be 100% intelligible. Articulation impairments do not fix themselves. Children need speech therapy services for these problems. But if the child is given proper speech therapy services, articulation impairments are very correctable, and children with articulation impairments do not need long-term special ed services. Think of most cartoon characters when you think of articulation disorders. Daffy Duck has a lisp, and Tweety Bird doesn't say TH, K, or S, for example. He says, I taught a putty-tat. When considering errors of articulation, the mnemonic aid used to remember what types of articulation errors there are is SOTA. SOTA stands for substitution, omission, distortion, and addition. Substitution errors occur when a sound is substituted for one that cannot be made. For example, as in the last slide, if I can't make the TH sound, I might substitute the F sound. So I might substitute in the word thumb, I might say thumb with an F. If someone could not make the R sound, they might say wed for red. So they are substituting the W for R in that case. These are substitution errors. O stands for omission, and that occurs when the sound is left out because it's too hard for the child to make. So if the child just says ed instead of red, it's difficult to make the R sound, and the child is making an omission error. D is for distortion, which occurs when the sound is not left out and is not substituted, but just doesn't sound right. Probably the best known example of a distortion is a lisp. A is for addition, and this occurs when an extra sound is added. For example, if I say glue instead of glue, that would be an example of an addition error. As teachers, we need to take note of how understandable or intelligible a student's speech is, and we need to consider how many different errors a student makes, because the more errors they make, the more difficult they will be to understand. We need to evaluate whether speech errors have an impact on the student's ability to learn, as well as an impact on the student's social acceptance. We need to observe these articulation errors carefully because, as I've mentioned, these errors are among the most correctable errors in all of special education. I'm now going to tell you about two other types of speech disorders, voice and fluency disorders. You should be able to describe each type and distinguish them from one another. The voice disorder, which is a problem with the pitch, loudness, or quality of the voice, is the least common type of speech disorder diagnosed because it is so subjective. We have to evaluate if the child's voice is really a problem, meaning that it affects their ability to perform in school or function socially, or if it is just a personal preference. For voice disorders, typically, the concern is either hyponasality, where there is too little air coming out of the nose, like someone has a really bad cold all the time, or hypernasality, where there's too much air coming out of the nose. You can think of Fran Drescher in The Nanny if you can remember that show. What educators need to consider is, does the student's voice make it difficult for him or her to be understood by others? If it really doesn't create problems in the child being understood, then it may not be worth addressing, and it may not really be a problem after all. But if it does create problems, if the sound of the voice is just so different, if it's hard to understand the child, then the child should get speech therapy for it. Another possible reason to address a voice disorder is if the student's voice is having such an unpleasant effect on others that the student is getting teased or excluded from activities. If this is not happening, if it is not affecting social adjustment, then it probably is not worth trying to remediate. A third consideration is whether the student is habitually abusing or misusing their voice. A person can damage their voice permanently if they are always talking in the wrong way, for example, yelling or straining their voice. So if a student is always hoarse, losing their voice, or struggling to make their voice work, it is worthwhile to pursue speech therapy. Voice disorders may have a physiological or medical basis, and if that's the case, then the medical condition needs to be corrected because then the voice disorder can be corrected. And so, with any voice disorder, it is always very important to get medical evaluation before one enters into therapy. Another consideration for a child who has a voice disorder is to investigate if it is a symptom of a hearing problem. Of course, there is no point to correct a voice disorder without first trying to correct the hearing problem. The next disorder that we will consider is the fluency disorder. Fluency refers to the pattern of the rate and flow of a person's speech. Normal patterns of speech include some interruptions in the flow of speech, but when interruptions of speech flow are so frequent and so pervasive that a speaker cannot be understood, and when the efforts of speech are so intense that they are uncomfortable, and when I say uncomfortable, I mean uncomfortable for the speaker and the listener, then the fluency disorder could be considered a problem. Disfluency is sometimes referred to as stuttering, but that term is considered archaic by many, and some even consider stuttering to be an offensive term. So the preferred terminology is disfluency. It is stereotypical to assume that someone who has a disfluency has mental problems or is insecure. Of course, if a person is really quite disfluent and they struggle a lot, they can become very shy or have low confidence or develop social interaction anxieties. Some famous people have been stutterers. Google that later if you want to impress your friends with trivia. Fluency problems can consist of blocking, repeating, or prolonging sounds in syllables, words, or phrases. Once again, boys are more vulnerable to the disability than girls, and there is growing evidence to support a genetic and physiologic base for disfluency. At one point in time, it was estimated that 2% of the population struggled with some disfluency. It can be common for children to experience some disfluency as early as preschool, and often the problem resolves. You can ask yourself, are the disfluencies beginning to occur more often in the student's speech? Is the student beginning to sound strained, as if they're producing a lot of effort to communicate? Is there a pattern to situations in which the student is disfluent, like when or to whom they are speaking? Is the student experiencing social problems because of the disfluency? And is the student concerned about his or her disfluencies? If the answer is yes to one or more of these questions, the student is likely a good candidate for therapy. In general, if the student is distressed about it, if the parent is concerned, or it continuously gets worse, it's best to have the child evaluated by a speech therapist. Recent studies show that children as young as 4 years old can start to show behavior or verbalize distress about disfluency, so it's important to get the child help as soon as possible. We'll get into language disorders in the next movie. That is all for this movie.